Hello, everyone, and welcome to today's event. The Leukemia and Lymphoma Society of Canada and Cell Therapy Transplant Canada are happy to present this webcast on CAR T-cell therapy and stem cell transplant treatment innovations in Canada. My name is Geoffrey Moll, and I am Community Services Manager at the Leukemia and Lymphoma Society of Canada, and I will moderate this online event. During this presentation, you will listen to various speakers. We are happy to be joined today by Dr. Sita Bhella, hematologist at the Princess Margaret Cancer Centre and engaged and involved in the development of the CAR T-cell therapy program. We will also hear Dr. David Szwajcer, hematologist and director at the Blood and Marrow Transplant Program and director of the Outpatient Leukemia and BMT Clinic at the CancerCare Manitoba. You will also hear blood cancer survivors, Camille Leahy and Keith Didham. We invite you to type your questions and comments in the Q&A box at the bottom center of the Zoom window throughout the presentation. And an LLSC staff member will monitor the questions, and I will ask some of them to the speakers at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all the questions. Today's presentation will be recorded, therefore you can rewatch it again on our websites. As we come together from across Canada, we recognize that we are on lands cared for by many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connections to this land enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancer. Before we present the first speaker, I want to share the important mission of our organizations. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community services lead in your region to receive personalized assistance and get connected to resources in your area. Reach out by calling toll-free 1-833-222-4884. We invite you to visit our website where you will find tailored information and resources in multimedia formats to address the variety of needs and preferences. This includes fact sheets, booklets, podcasts, animated videos, and recordings of all our webcasts. Visit bloodcancers.ca to read, listen, and watch all of these great resources. Let me introduce you to Dr. Stephanie Meyer, the Executive Director of Cell Therapy Transplant Canada, CTTC, since 2021. She is a molecular biologist by training with over 25 years of research and program management experience. Stephanie leads a small team of association management staff, which together with the various board members and committee chair volunteers, advances the work of CTTC in the field of stem cell transplant and cellular therapy. Over to you, Stephanie.
Thanks so much, Jeffrey. And so just a little bit more about Cell Therapy Transplant Canada. We are a professional society. It's a not-for-profit organization led by a board of directors. It's national in scope. We've got our members all across Canada, and our members our membership is made up of the physicians, the allied health members like nurses, laboratory personnel, quality managers, the pharmacist, all of the people involved in patient care. So from the product development and processing in the laboratories to treating the patients with these cell products and caring for the patients afterwards. So the mission of the CTTC is to be a community of excellence, leading national efforts to improve patient lives in hematopoietic cell transplantation and cell therapy through education, clinical care, research, and advocacy in Canada and worldwide. And our website is listed there on the screen if you'd like to know more. Next slide, please. And part of our membership is our patient, family, and caregiver members. There's three main ways to be involved with CTTC. You can just be a general website patron. You can go peruse our website, find all the information and resources that are there. If you'd like to become a member of CTTC, which is free for patient, family, and caregivers, you will receive periodic emails. You'll be able to attend our CTTC monthly webinars for free, and past conference presentations are also linked to our website. And if you'd like to become even more involved, rather than just a regular CTTC member, we have a patient, family, and caregiver advisory group. We hold monthly meetings with this group, and they're able to connect with each other and provide input to CTTC. So again, there's our website if you have any questions about what I've just stated, and back over to you, Jeffrey.
Thank you, Stephanie. Now let me introduce our first speaker, Dr. David Szwajcer. Dr. Szwajcer, I'm inviting you to open your camera and microphone. Dr. Szwajcer is an academic hematologist based at CancerCare Manitoba and the Health Sciences Centre in Winnipeg, Manitoba. He is the Manitoba Blood and Marrow Transplant Program Director and the Director of the Outpatient Leukemia and BMT Clinic at CancerCare Manitoba. He will address SCT with a focus on survivorship issues after stem cell transplantation. Over to you, Dr. Szwajcer.
I'd like to thank the Leukemia and Lymphoma Society for this opportunity to chat with all of you in this virtual format. As was mentioned, I have the privilege of directing the transplant program in Manitoba. And what I wanted to do today is spend a little bit of time talking about a few survivorship issues that I've come across that aren't as well discussed in the field of transplantation. So I have no relevant conflicts of interest to declare. In thinking about survivorship in transplant, the analogy of the story of Sisyphus has some resonance. Sisyphus keeps on being stuck behind this big boulder. The boulder keeps on rolling back, and so this is a frustrating experience. And many patients and families do report that the pathway of transplantation is not necessarily as straightforward as they may have hoped, but we, as well as other transplant programs across the world, endeavor to make this process as smooth as possible and hopefully get the boulder over the other side so that Sisyphus or the patient can reach the top of the mountain. So I know I'm speaking to a broad audience, and so in thinking about stem cell transplantation, there are usually two types of stem cell transplantation that we think about. We in the community think about an autologous transplant, which involves taking cells from the patient and giving them back to the patient following high doses of chemotherapy. And the other type of transplant that we think about is an allogeneic stem cell transplant. An allogeneic stem cell transplant is a transplant where we use genetically dissimilar tissue to transplant the patient. So we use tissue from the same species in the form of either a related or an unrelated donor to actually undertake the transplant. An emerging field in the world of solid organ transplantation is xenotransplantation, where tissue is taken from one species into another, but that is not something I'm going to further discuss today. In thinking about recovery from an autologous transplant or an allogeneic transplant, recovery is generally different. So in general, most people are able to recover from an autologous transplant in about 6 months or so, and are generally, all things being equal, able to think about returning back to work at about 6 months. Whereas for allogeneic transplants, people tend to take a fair bit longer to recover and are generally, if all goes well, able to recover and get back to the things that they wish to do by about a year after transplant. So pictographically, thinking about a transplant, there is a donor. In the setting of autologous transplant, the donor is actually the patient. So the donor gives cells, and those are eventually returned back to the donor that becomes the patient. Whereas with an allogeneic stem cell transplant, where we use cells from one person and give it into another, we collect cells from the donor, and after some complicated treatment, those cells are then given back to the patient, and then the patient undergoes recovery from their allogeneic stem cell transplant. So I wanted to spend a little bit of time talking about a few survivorship issues that are emerging as potential sort of topics of importance in the transplant literature. I'd like to spend the next little while chatting about post-traumatic stress disorder, the issue of caregiver burden and how we can address it in the changing healthcare environment in which we practice. And then I'd like to touch on a topic that I don't think gets enough attention in either the literature or in some of the counseling that we do, and that's the concept of returning back to work after a transplant procedure. So the first item I'd like to discuss is a condition called post-traumatic stress disorder. So in thinking about the stem cell transplant journey, patients and their families undergo a fair bit of preparation. This will involve counseling, a bunch of testing, potentially talking to other people who've had a transplant. The patient undergoes a transplant supported by their care team and the family, and then there is a period of recovery. And all of this is usually a very busy time where patients and families don't necessarily have a lot of time to process the experience. A lot of patients that we transplant in our program find their way to being admitted to our leukemia and transplant ward with a new diagnosis of conditions like acute leukemia, get complicated therapy for their acute leukemia, and then undergo a transplant and then undergo a recovery, all in the course of maybe 4 to 6 months. PTSD is defined as a mental health condition that's caused by an extremely stressful or terrifying event. And many people will think about the process of undergoing a transplant as a very risky and, in retrospect, potentially terrifying event. There are a few elective procedures in the practice of medicine with associated treatment-related mortalities for an autologous transplant, somewhere between 1 and 5%. That is the risk of death being about 1 to 5%. And we know that the treatment-related mortality associated with allogeneic transplant is on the order of about a 1-year risk of death of about 20%. We know that there are certain things that predispose people to PTSD, and that is having a baseline history of mental health challenges, having little or no social supports or family supports. We know that a lack of resilience can increase one's risk of developing PTSD. And we know that prolonged complicated hospitalization, such as on a transplant unit or in the ICU, can predispose people to developing PTSD. We know from published literature that the greatest risk of PTSD occurs somewhere between 6 months and a year after having the procedure. PTSD can manifest in a variety of different ways. It can manifest as having anxiety, or depression. It can manifest as having intrusive thoughts where one thinks about either hurting oneself or others. It's possible that people have nightmares or flashbacks. People can become hypervigilant. A lot of patients will report difficulty sleeping, and a lot of patients will report increased use of recreational pharmaceuticals. There are a variety of different strategies that have been found to be helpful to treat PTSD. Probably the most important thing for healthcare teams and family members is to recognize risk factors for PTSD to allow people to get the appropriate therapy. There are a lot of counseling strategies such as cognitive behavioral therapy and other psychotherapeutic approaches that have been very helpful in treating PTSD. We know that treatments or activities such as meditation, mindfulness, and increased physical activity can be quite helpful. We know that open dialogue with the healthcare team and family and friends can also be helpful. Patients find journaling very helpful to address some of their concerns. And finally, there's a growing awareness that there are various medications that, with the help of appropriate counselors, can help people resolve their PTSD. I'd now like to switch topics and talk about caregiver burden in the context of care models that are evolving. So historically, most transplant programs, including ours and Dr. Bella's, provided the majority of their care to patients or acute care for patients in hospital. And that model is changing for a variety of reasons. We know that many centers are adopting a day hospital model of care where patients can get a lot of their care coming into a day hospital without requiring inpatient care. And a new and emerging model of care that's becoming popular both in Canada as well as in other jurisdictions in the world is a hospital at home model where there's very limited involvement at the facility, but where most of the care is delivered in the patient's home with visits from advanced care providers on a daily basis. There are a variety of reasons for this shift in care. Patients and family members appreciate being at home or not being hospitalized. There is a decreased cost associated with either a day hospital model or a hospital at home model. And we know that following the pandemic, a lot of patients were successfully treated with these types of models. And so many jurisdictions are now maintaining those models as we transition into a post-pandemic healthcare treatment period. So there are some challenges and opportunities with adoption of ambulatory care models like I talked about. Many caregivers take on much more of a role in terms of system navigation and coordination than they may have when patients were hospitalized for prolonged periods of time. Caregivers are being asked to manage complex care needs at home. Caregivers are generally unremunerated by the healthcare system. Caregivers generally want to help their significant others or family members or friends, but are untrained. And many of these informal caregivers that the healthcare team relies on, such as family members and friends, may have other roles. They may be part of the labor force. They may have family that they need to look after. They may have children or elderly parents they're also providing care for. There are emerging programs all across the world to try and address caregiver support and making caregivers feel much more comfortable in their role. Several U.S. institutions have an initiative called BMT Care, which involves a boot camp type approach where there are 8 to 10 sessions offered to caregivers with other caregivers starting in the pre-transplant period up to day plus 60 after transplant, talking about issues about caring for the patient, issues of self-care, and talking about how care will evolve as the patient journey evolves. Several programs have formal home-based evaluations, asking, is the home appropriate for care? What is the comfort of caregiver and patient in terms of using wearable technologies or using telemedicine? And what are the dynamics between the caregiver and the patient? Do the caregiver and the patient get along? In Canada, we do have programs under employment insurance consisting of compassionate care benefits. In the province of Manitoba, we have a primary caregiver tax credit, which does provide monetary benefits to patients. In our program, we are looking at formalizing caregiver program as part of introducing a day hospital model of care. Finally, I'd like to finish off these sort of small topics on survivorship, talking about return to work. Nothing is more potentially anxiety-provoking than a discussion with one's healthcare provider at the insistence of one's insurance company about the issue about returning back to work. In my experience, most patients of working age express a desire to return to work. Many patients have been out of the workforce for a prolonged period of time. Several younger patients that I talk to have never entered into the workforce and may not have completed their education prior to thinking about work. And there's another large cohort of patients that I follow that are close to retirement. We know from studies that have been done in Europe and North America that 60% of patients who undergone an allogeneic transplant are able to return back to work, full-time work at 5 years. And that the corollary is that 40% of individuals are not able to return back to full-time work. Most workplaces are very enthusiastic about working with their employees to reintegrate them back into the workplace, thinking about gradual return to work policies and flexible scheduling. There are a variety of things that prevent patients from being successfully able to return back to work. A small but not complete list includes challenges related to graft versus host disease, which is a medical challenge that patients with allogeneic transplantation can experience. Fatigue is not uncommon for patients that have had a transplant. A lot of patients report a brain fog phenomenon following a transplant. Sleep and inability to get to sleep is a major challenge for patients who've had a transplant. Anxiety and depression may be issues in the post-transplant period. And finally, there's issues around readjusting to one's family and friend group and social network after a major medical procedure such as a transplant. There are a variety of folks who are willing to help in terms of thinking about reintegration back into the workforce. The healthcare team is very committed to working with patients to try and get them back into the workforce. Family is usually willing to also help. Many centers have psychosocial oncology departments which have provision for vocational rehabilitation, probably most developed in the province of British Columbia. And finally, the Canada Pension Plan has a lovely program that is probably not as advertised as it could be, called the Disability Vocational Rehabilitation Program, which provides very intensive rehabilitation with a career counselor and educational opportunities for retraining for individuals who've had a major leave out of the workforce, which I've worked successfully with to integrate several patients that I follow back into the workforce. Just a few selected resources available for you that may be of interest on post-traumatic stress disorder. a few resources, some of which are found on the Leukemia and Lymphoma Society website for caregiver resources. And then a few resources, one from Britain, from Anthony Nolan on returning back to work, and as well a website from the Canadian Partnership Against Cancer on resources available across the country on returning back to work. So with that, I will return the microphone over to Jeffrey Mole, and I will look forward to the question and answer period.
Yeah, so thank you very much, Dr. Szwajcer. We will now hear from Keith Didham. Keith, please open your camera and microphone. Keith lives in Corner Brook, Newfoundland and Labrador. He was diagnosed at 54 years old with chronic myelogenous leukemia on January 23rd, 2009. He received a stem cell transplant in Halifax, Nova Scotia on August 23rd, 2020. And he's here to tell us about that. Over to you, Keith.
Hi, as Jeffrey said, my name is Keith Didham, and I was diagnosed actually, I live in Corner Brook, Newfoundland. It's pretty cool and snowy here today, but this is Newfoundland. That could change anytime. In November in 2008, I celebrated my 54th birthday. I was fairly active. I played basketball twice a week. I snowshoed, I cross-country skied, I downhill skied, I worked full-time, I lived a normal life, and considered myself fairly fit. On Thursday, January 22nd, 2009, I played basketball with a group of my friends, as we normally did on Thursday nights. The next day, I was diagnosed with chronic myeloid leukemia, and I haven't played basketball since. However, to go back a little bit, around October of 2008, I started to notice that I was having some shortness of breath and I was tired much more easily than normal. Eventually, walking became a chore. At that time, I also noticed that I was having discomfort in both my feet. And that was most evident just after I started playing basketball. And every time I played, I'd have much discomfort. And I thought that I had gout based on my understanding of what gout was, and some of my friends have had it. That continued every time I played. So on the 21st of January 2009, I had an appointment with my family doctor, Dr. Tim Griffin, who agreed that my symptoms seemed to be gout related, and he sent me for blood work, gave me a requisition. And not feeling any urgency, I decided that I wasn't going to go for blood work that day. And I didn't go the next day, but the following day, after having a nice relaxing breakfast with some friends, I decided to go for blood work in the morning. And at 2:03 that afternoon, it was on a Friday, I was in my office working away when my phone rang, and that was Dr. Griffin. And not being prone to panic, I was somewhat concerned because obviously he had gotten my blood work results and he had called about them, and obviously something was up. He suggested that I come down to his clinic, and he wanted to have a discussion with me. And I told him, listen, I can handle whatever it is, just tell me, and tell me over the phone, which he did. And then he suggested that I go down and be admitted to the hospital right away, which I did. So I was admitted to the hospital that afternoon. My initial treatment with Dr. Griffin, he said the prognosis with the disease was fairly good, considering as an adult and that it was CML. And generally, he said with the treatments that were available, the prognosis was good, which made me, while concerned, I wasn't worried. My initial treatment was with medication, hydroxyurea, and then Gleevec. However, my response to Gleevec, while trending in the right direction, wasn't trending as quickly as what they had hoped and what was expected. So the suggestion was made that they try a different medication option. And I kind of had some concerns about that based on nothing, only not wanting to change a whole lot, I guess. I asked if I could have another opinion. So I did get to see Dr. Jeffrey Lipton at Princess Margaret Cancer Centre in Toronto in April of 2010. And he reviewed my history and suggested that I have another bone marrow biopsy just to double check everything, which he carried out immediately. And the biopsy identified some additional genetic changes that wasn't expected by me for sure. And it was determined that I had developed monosomy 7. And the condition necessitated a transplant as the only treatment available at that time. I met with Dr. Stephen Kubin in Halifax, who became my transplant doctor in late May of 2010. And he explained that the transplant was all about the positives and the negatives. He told me what to expect. He did tell me there was a 50% chance of the transplant being successful and survival rate was good, which also meant that there was a 50% chance that I wouldn't survive. And being an optimistic person that I am, Dr. Kubin, I said to him that, Doctor, the statistics for survival are going to improve, or some other poor bugger is going to die, because it's not going to be me. And he just smiled and said, well, that's the right attitude to have gone into this. And he asked me how many siblings I had, and added that there was a 25% chance one of the siblings would be a match. And I told him I had 3 siblings, 2 sisters and a brother, in which he informed me, said, most likely you're not going to have a match. But there were other options available. And luckily and thankfully, all 3 siblings were considered acceptable matches. And my brother turned out to be the eventual donor. And I realized not everybody is so lucky as I was there. My partner and I flew to Halifax on August 4th, 2010, and I was admitted to hospital a couple of days after that in preparation for the transplant. And thankfully, she was able to stay in the room with me as my primary caregiver and supporter through all this, which was absolutely invaluable for somebody going through this procedure. And she was a caregiver for much long afterwards too. I had my transplant on August 12th, 2010. I was released from hospital approximately 5 to 6 weeks after that. And as an outpatient, I stayed in Halifax, going back and forth to the hospital until I was released from their care in late September. And there's no hematology clinic or department in my hometown of Corner Brook. So I was transferred directly to the Health Sciences Centre in St. John's. And we flew in there a couple of days later, and I attended the day clinic in their ambulatory clinic, and I was released from their care, and I returned to Corner Brook on August 8th, 2010. And for most people, I'm sure you don't know, Corner Brook and St. John's are 690 kilometers apart, which is a 7-hour drive by road in good weather without any stops. And I can say I know that drive well. I've been back and forth quite a few times. I did have periodic appointments with Dr. Kubin in St. John's for quite some time after my transplant and after my return home. And I discussed with him the options of returning to work, returning to a normal life, basically, work being one of them, and all within reason, of course. And thankfully, everything worked out well, and I had clearance to return to work by the end of October in 2010, a little shy of 3 months after my transplant, which was really, really good. And I restarted work on the 6th of December of that year. And I'm still working now at 70 years old, although I have set my retirement date finally for this March. Also, during my early post-transplant appointments with Dr. Kubin, we developed a distancing and hygiene protocol where I could return to one of my biggest passions, which was coaching basketball. We did physical distancing well before COVID. I coached both senior and junior high school teams for the first 3 years after my transplant. And I started pretty well just after I came back to Corner Brook, after I got clearance to go to work. And this included 6 practices and a couple of games a week. And if you're coaching high school kids, you can be guaranteed you're going to be exposed to germs. And thankfully, I was in close proximity to them, but nothing ever took. And I got through it very, very well and had no issues. And I retired from coaching in May of 2022, 50 years after I coached my first team. My post-transplant experience has generally been very, very good. I've had some issues with GVHD, which started almost immediately after my transplant. I had minor skin irritations and itchiness, some blotching and discoloration. I've also had some lung issues where I experienced shortness of breath and reduced ability for physical exertion. Mostly I've had a problem with my eyes, which have been irritated pretty well constantly since my transplant. And this is bothersome, to say the least. And my ophthalmologist has prescribed a compounded eye drop that I use, which has been really good after I started to use that. It's still irritated, but it's not even close to what it was before. And the GVHD problems that I have been well managed over the years for the various medications, and I'm living almost a full life 15 years out. I did develop prostate cancer in 2020 and had radiation treatment for that in 2021. And I'm now monitored regularly and everything has been good so far. I've had an outstanding medical team and a wonderful support group around me for the whole duration of this. I still have regular follow-up appointments in St. John's with my hematology staff, my hematologist, Dr. David Jones, and my dermatologist, as well as appointments with my ophthalmologist and my respirologist here in Corner Brook. And they all monitor everything that's going on with me, and my family doctor, obviously, and they address any issues that I have. And my recommendation to anybody who has to go through this process is to maintain a positive attitude as much as possible. Not every day is going to be all roses, but we can certainly hopefully experience something positive and good in every day. And also try to return to as normal life as possible. And what is normal for me now is not what was normal for me years ago, and is not what would be normal had I not experienced any of this. But I realize that, and what's going on now is my new normal, and I'm fine with that. We just do what we can and continue. Thank you.
Thank you, Keith. For those who don't know, GVHD stands for graft versus host disease. So yeah, I wanted to specify that in case you didn't know. So now I'd like to introduce Dr. Sita Bhella. Dr. Bhella, please open your camera and your microphone. Dr. Sita Bhella completed her medical school training at Western Ontario. She completed internal medicine and hematology residency at the University of Toronto, and then went on to do a leukemia and allogeneic bone marrow transplant fellowship at the Princess Margaret Cancer Centre in Toronto. She completed a master's in education and has a strong interest in quality of life improvement and innovation. From 2015 to 2019, Dr. Bhella was an assistant professor at Queen's University, where she was the autologous stem cell transplant medical director. Currently, she is the autologous stem cell transplant medical director at the Princess Margaret Cancer Centre and engaged and involved in the development of the CAR-T cell therapy program. So over to you, Dr. Bhella.
Thank you very much, and thank you for having me here today. It's great to see all the attendees that are participating today. So thank you for taking time out of your day to join us to talk about CAR-T cell therapy in Canada. These are my disclosures. And then just a little bit, I treat lymphoma, myeloma, auto transplant, and cell therapy at Princess Margaret. So what we'll discuss today is a bit about CAR T-cell therapy, what it is, what's involved in the procedure. We'll review current indications for CAR T-cell therapy in Canada. And I was just looking at the chat, and I know there's some questions about emerging indications as well, so we can touch upon that. We'll discuss what a patient journey to CAR T-cell therapy looks like, although Camille will discuss that in much more depth after this presentation. And we'll discuss side effects that can occur with CAR T, both acute in the first 30 days post-CAR T, as well as long-term side effects. So I just wanted to start off with an imaginary case. So we have Mr. Samuels, who had DLBCL a number of years ago, treated with R-CHOP. Then it had relapsed, was treated with R-GDP and a stem cell transplant, an autologous stem cell transplant. Unfortunately, he met with his hematologist, and his lymphoma came back after his stem cell transplant. And his hematologist discussed with him that there was a new treatment that was available called CAR T-cell therapy, and it was the only potential curative therapy for his lymphoma. So his questions were, what is CAR T-cell therapy and what is involved with this? So CAR T-cell therapy, just to talk a little bit about T cells. So T cells are a part of the immune system, and their function is that they recognize abnormal cells in the body. They're on surveillance, they recognize virus-infected cells, early cancer, and can then act on killing them. Unfortunately, cancers have developed mechanisms to evade killing by T cells, and a new therapy emerged where we modify the receptors of T cells so that they can recognize an antigen on a cancer cell and then target it for destruction, both by direct activity as well as engaging the individual's own immune system to attack the cancer cell. And so here's a picture of what a chimeric antigen receptor is, and what's engineered in a lab is that you have your antibody portion that recognizes a part of the cancer cell. And every cancer cell has what's called an antigen, or a little protein on the surface of the cell that's specific to the cancer cell. And so the chimeric antigen receptor recognizes that and then can target that cancer cell for destruction. This technology can be used in many different types of cancer. It may also be used in the future in autoimmune disease as well. And so the CAR T-cell therapies that we have available in Canada right now, for the large part, recognize CD19 on lymphoma cells and leukemia cells, the CD19 being the address marker on the surface of the lymphoma leukemia cell. We will hopefully in the future have CAR T-cell therapy for myeloma, and the CAR T-cell therapy for myeloma that will be available recognizes an antigen called B-cell maturation antigen. The other piece about CAR T-cell therapy is that it grows so it's infused into the person. It's a living drug, and it continues to grow and work over time on constant surveillance for that antigen or that marker on the cancer cell. So that's a little bit about how CAR T-cell therapy works. So one of the things is choosing the right target for CAR T-cell therapy. So we need to find something that's expressed on cancer cells and is not expressed on non-cancer cells, or if it is expressed on non-cancer cells, the absence of those normal cells is tolerable and manageable. So CD19, which is the majority of CAR T-cell, the target of the CAR T-cells that we have available, is an ideal target because it targets B cells. BCMA is an ideal target for multiple myeloma as it targets plasma cells. There are many CAR T-cell products at various stages of approval across the world, and speak to your hematologist about what products are available at your institution and your jurisdiction, as it may vary throughout Canada, and this information may change in the coming months. I know that there was a question in the chat about the indications for CAR T-cell therapy. So when do we use CAR T-cell therapy? Generally, currently, this is for relapsed refractory disease. So for those with acute lymphoblastic leukemia, generally this would be after 2 or more lines of therapy. In the pediatric setting, Tizacel, and that's the name of the agent, is generally used. For adults, there are 2 different agents that are available, Tizacel and Brexacel. We have a number of agents that are available for large B-cell lymphoma. Recently, it's become available in those who have who have relapsed within 12 months of first-line therapy, or who have primary refractory large B-cell lymphoma. And it has been available for a number of years for third-line therapy, and there are a number of different agents that are available. Mantle cell is an emerging indication as well. I saw a question in the chat about whether CAR T-cell therapy was available for those who had not received a second-line therapy like a BTK agent, BTK inhibitor agent. Right now, it requires standard therapy plus a BTK inhibitor. And it's also available for follicular lymphoma for third-line plus therapy. There will be new agents emerging in large B-cell lymphoma. Liso-cel is another agent that is emerging as well. We do expect that CAR T-cell therapy for myeloma will be available in the coming months to year, although I don't know the timeline specifically. The indications are evolving. It's possible that if you look back at this presentation in a few months from now, there may be even more indications. So it's always best to connect with your your local advocacy rep or your hematologist. So Mr. Samuels meets the indications for CAR T-cell therapy. He has lymphoma that's relapsed post-autologous stem cell transplant. And he wonders, now that I meet indications, what are my next steps? How long does it take for these CAR T-cells to be manufactured? And am I well enough to receive this therapy? So what the clinical team will do is make sure that the patient is eligible to receive CAR T-cell therapy. I know many of you on the call have had an auto or an allo transplant and potentially a CAR T cell infusion as well. And with autologous stem cell transplant, the chemotherapy that's involved is quite intense. The chemotherapy that's prior to CAR T-cell therapy is not as intense. And so as a result, sometimes we will consider patients who are older for CAR T than we would for autologous stem cell transplant. But generally, we'd be looking for good general health, good functional status, good organ function status, like kidney, liver, heart status, the ability to collect T cells, having a caregiver, meeting the current funded indications, and with auto and allo transplant, generally your disease needs to be responding to chemotherapy in order to go ahead, but that is not a requirement for CAR T-cell therapy. Medical tests are required before CAR T-cell therapy just to make sure that we meet all of these eligibility criteria. So depending on the disease indication, you may need a PET scan, CT scan to assess the disease before and after, echo and ECGs, blood tests, urine tests, and depending on the indication, you may or may not need a bone marrow biopsy. So the first step is to collect the T cells. And so I know many of you have had an auto transplant previously. So the step to collect the T cells is actually quite similar. You'd go to an apheresis unit. There'd be an IV in each arm. Blood would leave the body, go through the apheresis machine, and be separated into layers, and then the part that's not collected would be infused back into you. This is an example of what an apheresis product looks like. That being said, this is an exaggerated example of what an apheresis product looks like, with the white cell layer being extremely big here, because this is an apheresis product of someone who had acute leukemia. Generally, though, the layer would be quite thin, and it would mostly be plasma, and then red cells at the bottom. So this collection of T cells generally only takes about a day for most patients, perhaps 2 days in some circumstances, while we collect the target amount of cells. And then these cells are then sent to an external manufacturer. The products that were mentioned on the other page with indications are by external manufacturers, commercial manufacturers. Generally, these they're sent to the States. There's a center in New Jersey, and I think there's a center in California. There's limited number of manufacturers around the world, and it generally takes 3 to 4 weeks to once they have your cells to manufacture the product. In some cases, some products take longer than others, but generally around 3 to 4 weeks. The challenge is that while you're waiting for your product to be created, your lymphoma or your other or the other hematological malignancy that you may have may progress. So many people will require bridging chemotherapy or radiation therapy in that period of time where this product is being manufactured. So this is what the manufacturing product looks like. The external manufacturer gets these T cells and ultimately sends the cells back to us. What they do on their end is they select T cells, they activate them, they do the gene transfer, there's expansion, quality control, cryopreservation, and then they ship the cells back to the site where you'd be treated. Generally, CAR T centers are also allo and auto centers, just because of the amount of expertise at various levels. There needs to be a cell processing lab involved, and so it tends to be a larger center. So once you have the cells back, and just a comment again about bridging therapy, because it can take 2 to 4, possibly even longer to get CAR T cells. Bridging therapy may be required. You need to keep the disease under control, just so that we have enough time to get the cells back to us. Generally, that would be with chemotherapy, radiation, sometimes what may be suggested. Sometimes people don't need any therapy if their disease is slow growing, and so that would be a decision made by the treating hematologist team. And so once the cells are back, you're ready to get started with the next step. And so the next step would be lymphodepletion chemotherapy. And so lymphodepletion chemotherapy, generally for the most part, is fludarabine cyclophosphamide, and it's a T cell depleting regimen. And the goal is to deplete your own T cells so that when this manufactured product is infused, there's space for these infused CAR T cells to expand and proliferate, and it allows them to expand and engraft in the body. So regimens that are used are generally cyclophosphamide fludarabine or bendamustine as an alternative if there's an allergy to one of those two medications. And then it's followed by the CAR T cell infusion. Lymphodepletion chemotherapy and the CAR T cell infusion can be done as an inpatient or outpatient. It depends a little bit on the center's resources. And then the CAR T cell infusion itself, it really just looks like a transfusion. It's quite quick, and there is the risk of an allergic reaction, but you're given a lot of pre-medications to prevent that from happening. And then you're carefully monitored. And then similarly to an auto or an allo, the day of your infusion is called day 0. So we'll go back to the case in a second, but there are certain side effects that we look out for post-CAR T-cell therapy, and this is why you need to be in the vicinity of a CAR T-cell therapy center for 30 days post the infusion. The big side effects to be on the lookout for are cytokine release syndrome and neurotoxicity, which we're going to go into in a bit more depth in the coming slides. There are long-term toxicities that we look out for, such as hypogammaglobulinemia, which increase your risk of infections, and we look out for other malignancies developing as well. So back to the case. So Mr. Samuels is admitted. He gets his lymphodepleting chemotherapy. He gets his CAR T-cell infusion. And now he's about 5 days post CAR T-cell infusion. And then he starts to experience fever, low blood pressure, chills, and every day he has blood work as part of his evaluation, and his inflammatory markers are rising, indicating that the fever, low blood pressure, chills are probably not just an infection, but could be cytokine release syndrome. And so I think I just answered my next question. What is he experiencing? Is this common post-CAR T-cell therapy? So what he's experiencing is called something, or it's called cytokine release syndrome. So the first 2 weeks post-CAR T, the CAR T cells are infused, they expand rapidly, and that can lead to a lot of inflammation in the body. And so as these CAR T cells are infused, they're breaking down the lymphoma or leukemia cells. There's a lot of inflammatory markers released in circulation. And as a result, that can lead to fever, headache, difficulty breathing, low blood pressure, lack of oxygen. And so that's why patients need to be monitored carefully in that period post-CAR T. We can also track how this inflammation is progressing, and this is what we do as in the inpatient or as an intense outpatient monitoring, is looking at inflammatory markers like CRP, ferritin. Most people will get some degree of cytokine release syndrome, and the severity depends a little bit on the disease indication and the product that is being infused. But it tends to be severe, and I would say like 10% of patients, but the majority of patients will get some degree of this. Sometimes you can just monitor if it's very low grade, but if it persists, we generally will step in with an agent called tocilizumab, which blocks one of the inflammatory receptors, and most people will respond to that. We do have other agents like steroids and other immunosuppressive agents that can be used. Some diseases tend to have more cytokine release syndrome, like mantle cell lymphoma, so it depends a bit on the indication and the agent. Cytokine release syndrome can affect any multiple organs, any organ. Generally, we see cardiovascular, respiratory, fever, low blood pressure, but we do sometimes see rash. We do sometimes see bleeding. So these patients are very carefully monitored intensely by a team with expertise. And then Mr. Samuel discovers that he has neurological findings after CAR T-cell therapy. So a few days after his CRS, where he was treated, he then develops difficulty with word finding difficulties, and he develops a decreased level of consciousness. He's rushed to imaging, so this is a picture of him being rushed. So what side effect is he experiencing? So post-CAR T, and this doesn't happen in everyone, you can develop neurotoxicity as well. And it's thought that perhaps the cytokines or the CAR Ts are, the pathophysiology is not well understood, but there may be some crossing of the blood-brain barrier. And the symptom can be anything. It can start off as a tremor. It can also include dysgraphia or handwriting difficulties, which is why we monitor these patients very carefully. Speech is a common symptom. Headache and seizures and coma can also occur. Generally, we want to identify these symptoms early and then treat when indicated. Sometimes a tremor or handwriting does not require treatment, whereas more severe issues like speech issues or seizures will require immunosuppressive therapy, and it resolves in most cases, although certainly coma, seizure are very concerning. So we need to do careful monitoring and lots of education of our whole team, our nursing staff, our residents, fellows, MDs, everyone who's involved in the care of these patients, so that we can pick up early signs. And so these patients will have what's called an ICE score done on them, which really just asks them questions about orientation, naming, following commands, writing, and counting or doing math backwards. And then we can pick up on early signs and intervene as needed. And so that's why the very first 2 weeks post CAR T are there's quite intense monitoring, and then most people are then able to be discharged generally at around the 2-week mark. Sometimes with some agents, people can also be monitored and treated and do this procedure as an outpatient as well. So Mr. Samuels was discharged, he recovered, and so now that he's home, what can he expect? How can he protect himself against infections? And so he's home, and it's about a month post. The common things that we see post CAR T, so low counts is quite common. Sometimes people can be dependent on transfusions for months afterwards and may require GCSF or other medication to keep their platelets and white counts up. Depending on the type of CAR T that they received, so if they received a CAR T that was anti-CD19, they may develop what's called B-cell aplasia, where they may be at higher risk of infection and may require IVIG, depending on their clinical scenario. A low immune system is certainly something that can happen as well, and revaccination is considered after 6 months. I did see a question in the chat about when can live vaccines be considered. Varies per patient circumstance, because sometimes people may be on chemotherapy after a transplant or CAR T, so you should always ask that question to your treating hematologist, but generally that would be much more than a year or two after CAR T cell therapy. Fatigue can certainly occur, and then infections. So preventative medications should be considered, like valacyclovir, Septra, to prevent shingles and PJP. And then I know there were some questions in the chat about after having chemotherapy, other cancers have developed. So that's something that these patients will need to be on surveillance for, and certainly on surveillance for things like MDS and AML, which can occur post prior chemotherapy exposure. I did also see a question in the chat about PML, which is a very rare condition that can happen after neurological condition that can happen after multiple rounds of chemotherapy. I would say that's rare post-CAR T, but certainly something that you'd have to be on the lookout for. So all to say that long-term follow-up is really important after CAR T cell therapy. We often do this in conjunction with your home treating hematologist, as well as our long-term CAR T follow-up clinic, just to make sure that all of these issues are being addressed. So Mr. Samuels is in remission 1 year post-CAR T. He's recovered. He's returned to his regular activities, and he's carefully monitored by both his hematologist and the CAR T cell center. What I didn't address was how disease monitoring is looked at post-CAR T. It depends on the disease in question, but generally blood work, CTs, bone marrows if we're talking about acute lymphoblastic leukemia. So I won't get into specifics necessarily about that. Great. And so that's what I wanted to talk to you about today, about the CAR T-cell pathway, and then happy to take any questions. I think our questions are at the end.
Yes, exactly. Thank you, Dr. Bhella. All the questions will be answered at the end. We already have several questions for you in the Q&A box, but everybody can add their own questions if they want. We will now hear from Camille Leahy. I'm inviting you, Camille, to open your camera and microphone. Camille, passionate patient, advocate, and cancer survivor whose life was transformed by CAR T-cell therapy. Now cancer-free, she speaks about her journey to inspire others and promote access to groundbreaking treatments. As a keynote speaker, Camille champions resilience, hope, and early access to innovative therapies. Over to you, Camille.
Thank you, Jeffrey. So, hi, everyone. I'm Camille Leahy. In January of 2020, I was diagnosed with acute lymphoblastic leukemia. Obviously, that was quite a shock. I didn't have your typical symptoms that I believed were leukemia. Prior to diagnosis, I was feeling unwell. I had been on a sick leave from work, but I thought it was stress. I was in a toxic environment. But I got a new job and I was excited to start that in the beginning of January 2020. Unfortunately, I didn't get to start that new job at my local hospital. January 7th, they confirmed by bone marrow biopsy that my cancer was aggressive. It was acute lymphoblastic leukemia, and that I would have to go to Princess Margaret Cancer Centre to begin a month-long treatment using a protocol they called the Dana-Farber protocol. Now, at that time, I was told that my cancer was very treatable. After that month of induction, the plan was to be discharged and continue maintenance therapy over a course of 2 years. After the month-long induction, unfortunately, I was told that the cancer was not gone and that they would like to try another drug. This drug was called blinatumomab. I tolerated this drug really well, and I stayed in the hospital again for another month, all of February 2020. So that was 2 months, and I'm a single mom of, at the time, she was 12 years old, so that was really difficult. But I was able to see them during those first 2 months, so that was great. At the end of February, for some reason, they believed that my cancer was resistant to treatment, and at that point, they recommended a stem cell transplant. Now, that's at the end of February, beginning of March 2020. Now we have entered a pandemic. So we were looking for a donor, a match for myself. I as well, like Keith, I had 3 siblings. Unfortunately, none of mine were a match. So they said that they had found 2 matches. One of them, or they were 9 out of 10 matches, they said. They went with the one that they thought would be best. So I began preparing for that stem cell transplant with intense chemo and radiation. And July 9th of 2020 is when I had that stem cell transplant. I remained again in hospital for another month, the whole month of July. Again, not being able to see my daughter or anyone at that point because we were in a pandemic. But I fought, and after the month of healing after my transplant, my counts had gone up and I was able to go home, and that was obviously amazing. So I was beginning my healing journey. So I was getting stronger. I was starting to get back to my normal life, enjoying normal things. During my transplant preparation, I was on a lot of steroids. I had lost the ability to walk. I wasn't walking well. I had to use a cane and a walker. I was always in constant pain. But But months after my stem cell transplant, I was starting to feel great until one morning, 8 months later in March of 2021, I'd woken up with some pain in my neck. I didn't think anything of it, but when the pain started moving to other parts of my body and began to get worse, I knew that something was wrong. I went to Toronto General Emergency Room, and unfortunately, just from the blood test, I was told that the cancer was back. And for it to be found in just that blood test, I knew that not only was it back, that it had spread through everywhere. I was met with my transplant team from Princess Margaret and was informed that there was nothing left for me at Princess Margaret with the stem cell transplant team. So I was told that I would be sent back to my leukemia team that I worked with at the beginning of my diagnosis. I was recommended a protocol called Hyper-CVAD. And when my Dr. Minden had, he started reading, the types of chemotherapy drugs that were involved in this protocol, they just sounded familiar. And I remembered that some of those drugs were in the initial induction that I had done in January of 2020. Now, again, remember, I'm alone at this point, again, in the hospital, and at this point told that I have no other options. I knew that if I did that chemotherapy, especially being alone with no support, I knew that I wasn't going to make it. I knew that my body wasn't strong enough and I couldn't handle that intense type of chemo anymore. While I laid there in the hospital, the doctor said, okay, well, we'll try something else. He then tried to apply for the blinatumomab that was successful prior, but unfortunately, because I'd already had 3 rounds of that, I was denied that medication. Then I was recommended something called inotuzumab, but the requirements for that drug was to be an outpatient. But at this time, I was very sick. Now, I had a lot of time to think, and I had remembered one of the visiting doctors while I was undergoing my preparation for stem cell transplant, Dr. Jonas Madsen. He was visiting and he said to me, Camille, if this stem cell transplant isn't successful, there are other things out there. And at that time, I really truly believed that the allogenic stem cell transplant was my cure. And I had full faith in it. But I was curious, so I asked him, like, what? And he said, there's things like cell therapies and something called CAR T cell therapy. Now, at that time, I put that at the back of my mind. But now, laying in that hospital room, not even knowing if I was going to be approved for the inotuzumab, that memory popped in my head, and I began researching. And I had asked another one of my visiting doctors, Dr. Carolyn Chung. I said, what about this CAR T cell therapy I've heard about? And she said that there was a clinical trial that had just opened up in 2019, the end of 2019 in Ottawa for a CAR T cell, and was open to adults over 25 with relapse refractory ALL, or I believe lymphomas as well. When she mentioned that it was in Ottawa, I quickly realized my very close family member, Jenny, works as an ER nurse at the Ottawa Hospital. I asked her about it, and she said that she would research it. So we were both researching. She had heard about a online webinar that Dr. Kekri, who is the one that was running this clinical trial, was in charge of. She had an information webinar. So Jenny had asked her questions and asked, how would somebody get into this trial? And that's when Dr. Kekri said, a referral from the doctor. Now, at this point, I didn't know that the referral had already been put in. So I, myself, and Jenny had been emailing Dr. Kekri. I was finally contacted by the Ottawa Hospital, and they told me that they were considering getting me into this trial, but they had to make sure that I was eligible. There was certain criteria that had to be met, and one of them was to have active disease. but my ALL was very aggressive, so it had to be treated. So I was discharged from hospital, began the inotuzumab, going back and forth every day to Toronto from Newmarket, and we cleared up the cancer, and I was accepted into the trial. I was able to arrange a place to stay with my family members who lived in Rockland, which is just about 40 minutes outside of Ottawa, or away from the hospital. So in June of 2021, I went out to Ottawa to do my intake with Dr. Kekri and her team. The night before that intake, I had some, I had the side of my face started to feel numb. So the next day when I got to the hospital and they were asking me questions, I mentioned the numbness in my face, and I saw in their eyes that there was something wrong, and they said, we're gonna have to do lumbar puncture just to make sure that everything's okay. Unfortunately, that lumbar puncture showed that the cancer had gone into my central nervous system. Now, because of the side effects of CAR T, like Dr. Bhella had mentioned, the cytokine release syndrome and neurotoxicity, that was a big no-no. I was automatically declined and told that I would have to return to Toronto to clear the cancer in my central nervous system. Now, obviously devastated, I went back to Toronto, began doing chemotherapy through lumbar punctures twice weekly, which was very difficult. But I didn't want to give up. I had been told that I still had a chance to get into that trial. So we cleared up that cancer in my central nervous system, and I made another attempt to go out to Ottawa. At this point, I believe we may have been able to do the cell collection, and that entailed what Dr. Bhella had described, the cell collection, and from there, 2 weeks later, so they sent this away. I did the first made in Canada CAR T cell. It was sent away to British Columbia, manufactured 10 days, it returned, and it was just like an infusion, and my modified T cells were infused into my body, and we started at day 0. I believe at day 30 was when I was told that I could go home, and I returned to my home, and I had to stay in Ottawa for a while away from my family, but finally after 6 months, I was told that I could go home to Toronto and just return every 6 months to Ottawa. And then finally it was only once a year. And now here I am 3 years later, post CAR T cell as of September 15th. It'll be 3 years cancer-free. So I'm very grateful for CAR T cell. And if anyone has any questions, yes, I will answer them after we are done. Thank you.
Thank you, Camille. Yes, sorry, we have to to shorten it a little. Thank you. Well, we really had a lot of incredible information today from everybody. Thank you to all our speakers for sharing your expertise and insights with us. We received many questions in the chat. I want to thank my colleagues who managed all the questions and answered a lot of them too directly. I'm going to ask some questions to all of our speakers, but I will ask all of you to stay as concise as possible so we can go through as many questions as possible and not go over time. So my first question would be for Dr. Szwajcer. And it's kind of two questions that I'm going to try to combine. How is it determined that a transplant was successful? And what about immunity status? When do we consider that immunity has gone back close to normal?
So figuring out that individuals are in remission is something that we do over time. And it really depends on what someone's underlying reason for having a transplant is. I undertake transplants for a variety of individuals with immune dysregulated disorders that are uncommon, and sometimes we have a particular genetic defect that we're trying to correct, and so it can be easy to check for correction of a genetic defect. In other cases, we follow people over time, and as long as there's no evidence of relapse in the medium to not so medium term, we're pretty confident that there is unlikely to be a relapse. In terms of immune reconstitution, there are several things that our program does. So we check to see what the T cell numbers are doing over time. So at a year, we check absolute numbers of CD4 and CD8, which are types of T cells, what those numbers are by flow cytometry. The other thing that we can do is check to see how people respond to immunizations. So our program, as well as Dr. Bhella's program, undertakes vaccinations, where we vaccinate people after they have transplants. And so we can, for instance, plant a tetanus vaccine or subject someone to a tetanus vaccine and see how their body produces antibodies. And that gives a very good functional readout for how their immune system is working.
Thank you, Dr. Szwajcer. So my next question is for Dr. Bhella. How can I best prepare myself to be eligible to CAR T cell therapy?
So that's a good question. I think it will depend a little bit on the indication or the condition that the person has about whether or not they need CAR T cell therapy. But the best way to try and position yourself is just making sure that you're very active, eating well, moving a lot, just keeping your functional status up. Because sometimes that can be a barrier to going ahead with CAR T cell therapy if your functional status is poor. I don't think that there is really anything else that you can do to better position yourself. I think it kind of depends on the person's particular scenario. Hopefully that answered the question somewhat.
Thank you. Now I have a question that is both for Camille and Keith as survivors. I would like to know, is there anything you wish you had known before you went through CAR T or stem cell transplants? Who wants to
Did you
start?
say, is there anything that I wish I'd known?
Yes.
No, I pretty well trusted my medical team. I was really lucky right from the get-go, and I put my faith in them and just let it go.
Okay, interesting. So trust. And Camille?
I mean, my part of the story, I remember I had no other options, and I had researched this, amazing treatment. So no, I was full ahead. I wanted to get into that trial. I believed in it a lot, and I still believe in it. I mean, I wish I would have known about it sooner.
Okay, thank you. And I think it's going to be last question, but also it's also for Dr. Szwajcer and for Dr. Bhella. What is the aftercare of these procedures?
So in terms of transplant, we as a program have a defined program of follow-up that is quite structured, and I think is similar at the various different centers across Canada. And so we will have guideposts for patients and their families over time to let them know what to expect in the post-transplant period. We have defined times. For instance, I saw several questions around vaccination, so we have defined times for vaccination. I generally bring up return to work sometime at the 3 to 6 month mark, just to get a feel for where people are in terms of their thinking. For patients who've had an allogeneic transplant, much of the first several months after transplant is taken up with thinking about viral illnesses that they might experience and thinking about managing prophylaxis for a condition that was mentioned before, graft versus host disease, or treatment for graft versus host disease. So we try to give a comprehensive patient map of where they're going to help them get to where they wish to be. I might let Dr. Bhella address the CAR-T topic.
Yes, so yeah, thanks, David. I would say our the CAR-T aftercare is very similar to the transplant aftercare in that there are certain like goalposts that we look at. We try to do the CAR-T aftercare in a shared care fashion, mostly because people are traveling quite far to get to Toronto, sometimes across the country to get CAR-T cell therapy. But essentially it's the same. You know, at the 1 month mark, 3 month mark, year mark, we're doing imaging to assess response. So we have guideposts with respect to when to look to assess response and to see how well and how successful the CAR-T therapy has been. And then with respect to aftercare, we're monitoring their immunoglobulins to determine whether or not they need IVIG. We're recommending vaccines at certain time points, generally 6 months plus, but often in like the respiratory viral season, which we're all in right now, we will often recommend doing those a little bit earlier just to protect themselves against COVID, influenza, RSV. We have seen that COVID be more like have a higher, there are more fatal cases post CAR-T. So that's certainly something that we're advocating for with respect to vaccinations and prioritizing that. And then we're also recommending aftercare with respect to looking at bone mineral density at the year mark, reassessing fertility where like applicable. So we have a set of guidelines that we follow. Thank you. Hopefully that was helpful.
Thank you. Yes, thank you all very much for all the questions. Thank you to our speakers for sharing their knowledge and their experience. So as I said, there was a lot of questions. If your question was not answered today or was not covered by an answer to another question, you will be contacted by one of the community services lead from LLSC to give you an answer personally. Before we sign off today, I would like to invite you all to our next event, the National Myeloproliferative Neoplasm Conference from February 25th to 27th. You can find information on our website and register there. Also, CTTC is partnering with HEMA Quebec and WMDA this year to hold a joint conference in Quebec City. From May 19th to 22nd, there will be a patient-focused session on Monday 19th on Victoria Day, and a virtual option will be available. The PFC Advisory Committee is working to put the patient session together, and more information will be coming to the conference website listed on screen. I'd like to mention that this presentation was made possible thanks to the support of Johnson & Johnson. Please remember that our organizations are here to help you. You can see the contact information of the Leukemia and Lymphoma Society of Canada and Cell Therapy Transplant Canada. Please note that a short survey will be sent to all participants after this presentation. We thank you for taking a moment to respond, as it helps us plan future events. Thank you again to all our speakers. Thank you to all our attendees for being with us today, and take good care of yourself.